Welcome to Diagnosing Health Care, a podcast featuring thought-provoking conversations about the latest legal, policy, and regulatory issues in healthcare. While these issues may seem like hurdles, we'll also look at the business opportunities and solutions that exist. Diagnosing Healthcare is brought to you by the healthcare lawyers at Epstein, Becker, Green, a leading law firm that has more than 40 years' experience serving clients in the healthcare industry nationwide.
Today on Diagnosing Healthcare, we will discuss how openEHR is already transforming how health data is managed and stored across Europe, and why it may soon disrupt the US marketplace. Hello, and welcome to our special series on interoperability. I'm your host, Nivedita Patel. I'm an attorney in Epstein, Becker, and Green's healthcare and life sciences practice based out of our Washington, D.C. office. Disruptive thinking is about thinking differently in ways that challenge the traditional ways things are done and make it possible for innovation to occur. As we discussed in our prior episode, using openEHR standards together with the FHIR standards that have already been adopted as part of the ONC's certification program can bring about the disruption needed to take interoperability in the US to the next level. While our healthcare systems may differ, when it comes to information technology and sharing data, we can learn a great deal from the experiences of our counterparts in other countries, particularly those countries that have similar IT adoption rates and similar variation in technologies. On today's show, we're going to talk more about how openEHR is already being applied in places like London and France, and hear about how examples like these could quickly become more common in the US. If you like what you hear today, please subscribe to the show. Diagnosing Healthcare is available wherever you get your podcasts. I want to hand things over to my colleague, Karen Mandelbaum. Karen is senior counsel at EBG and a former privacy and security official at the Centers for Medicare and Medicaid Services, with deep knowledge in all aspects of health data privacy and protection. Welcome, Karen, and thanks for leading today's discussion.
Thanks, Nivedita. In this second episode in our openEHR interoperability series, we'll learn about two solutions, One London and Anessia, both built to use the Better platform with healthcare data stored in an openEHR format. openEHR is not yet being used in the US, so we look to our European counterparts for examples on how it can be used here one day. Joining our discussion today is Alastair Allen, the Chief Technology Officer at Better. Alastair leads technology innovation and strategy for Better's suite of platforms, tools, and applications. In his over 20 years working in the healthcare industry, he has served in roles that run the gamut from engineer to product manager to architect. And we're excited to have him here with us today. Welcome, Alastair.
Thanks, Karen. Glad to be here. Looking forward to this afternoon.
Since joining Better, you've been responsible for overseeing the deployment of some major projects. First, can you give us a high-level overview of Better as a company and what you do?
Yeah, absolutely. So Better are an independent software vendor based out of Europe. We've been working in healthcare now for about 30 years, and we are about 150 people serving around 120 customers in 12 different markets. Our product is really focused on trying to simplify and improve health and care for health and care teams and accelerating digital transformation. We're really focused around the data problem and trying to adopt a different approach to allowing data to be held in an open, vendor neutral format that will allow innovation and application on top.
So let's jump in to talk about our first example. One London comprises 40 national health system trusts, 5 integrated care systems, and 1,400 general practices that serve a population of approximately 9 million people. Why is it so important to have a shared care plan solution for the entire city of London?
Great question. I think London is actually similar to many customers that we're working with at the minute. We're sort of seeing a shift, I think, from a traditional EHR centered or provider centered way of delivering health and care to more of a regional system that spans primary care, secondary care, all the way through to community and mental health, and to create a more integrated healthcare system based around the patient. And a key part of that is creating and providing digital services that allow health and care teams to collaborate together around the patient. And this is really important, especially for care planning. What we really want is a way where everyone has access to the same information, and they're able to get access through existing systems in a uniform way. And that will allow them to respond to each person's needs in the best way possible. But the reality in London, as many other places, is quite far from that position. We've got treatment escalation plans, crisis care plans, end-of-life care plans, all documented by different health and care disciplines in different ways and stored in different locations. And London is no different. There's a large number of EHRs, several personal health record systems, all deployed across London, making it really difficult to provide a single joint view of an individual's care plan. So we've been working with London to provide a single shared service that sits across all of those applications. So for anybody that presents to any care setting, the health or care team will be able to see and have access to their end of life or their care planning preferences. And importantly as well, the patient or the person has access to and can contribute to that, as well as their family or other informal carers as well. So this is what we've been working on with London. And I think there's a number of reports. I think the Lancet report came out recently around anticipatory care and advanced care planning. And it showed that people's wishes are not really being followed. I think end-of-life care planning is where we started with London. Most people in reality want to die at home, but are actually being brought into hospital or a care home. We need to start trying to listen to people's wishes, and I think we need the information available at the right place at the right time to enable us to be able to do that. So that's why I think solutions like this are really important.
So help me with understanding, how will solutions like Better support the ability to rapidly build the dynamic care planning applications that you're describing?
I think the key for me is the data. And I sort of mentioned that when I started. And I think the problem, unfortunately, with data is there's mountains of it everywhere. And a lot of it is dirty. It's quite often incorrectly modeled or captured and classified incorrectly. And historically, when we've tried to solve problems like this, we adopt what I call an application-centric architecture, where the data for each application is held by that application, it's managed by that application. And when a patient moves to another care setting, we have to then share that information or a subset of that information, and then it gets stored in another place, creating lots of silos, lots of duplicate entries, and making it really hard to get a joined up view. What we've actually done at Better, and we've been working on this for a number of years, is really adopting a data-centered architecture where we establish a common language at the data level. And that represents the information that's used across a particular care setting. All the applications then communicate using that data model, and it creates these interoperable systems almost as a side effect of that approach. And we do that using openEHR, and that provides us with a really robust and scalable modeling framework, but also with a really great library of community-created data models that accelerate our development. So that's kind of the core foundation, if you like, is getting that data right. But in terms of your question then, in terms of how we accelerate things, we need to do something with that data. And typically there's two main approaches. The first is we've open APIs according to the FHIR specification to access that data. But increasingly, a lot of our customers now are asking us, how do we speed up development? How do we build applications? And by the way, we don't really have any developers. So we've been spending a lot of time working on what we call low code development. So low code, for anyone who's not familiar, it's a bit like a Lego analogy. It's an idea of, through drag and drop, bringing together pre-assembled components and building an application. And typically it's non-programmers who do that. The thing that we've done differently is actually basing that directly on top of the openEHR data standard. So we're able to build entire applications that are integrated into that data model really quickly and out of the box. So that's the second layer of building the applications. But finally, and most importantly, how do we actually make that available to our users and to our patients? And I think, again, we've tried to take a little bit of a different approach here. We manage the applications centrally, but what we've done is created application level integrations with all of the different EHR systems across London. So if I'm a clinician working in a hospital and I use Cerner and I go into Jane Smith's record, I'm able to access Jane Smith's care plan directly within Cerner. I can see she's got a plan and I can view it. I don't need to go to another application. I don't need another set of credentials. So we're trying to make it really easy to complement existing systems, but equally managing the data in an open, vendor neutral manner at the center. That also means then we can quickly, when we need to make changes, we change the application in one place, and that gets immediately distributed across all of the care settings. In London, they have big ambitions. They want to move beyond advanced care planning. They're looking at diabetes, frailty, heart failure. You can use all of this underlying platform and infrastructure to build those services very quickly and then make them available across all of the care settings.
Interesting. One last question about One London. How far is the national health system in England? How far have they progressed?
In London, so we contracted in just at the start of the year. We are going live any day now. We went through a period of figuring out what to build, building it, and then obviously there's a lot of assurance around that as well. So it's been about 5 or 6 months of process, which is actually a fantastic, I think, outcome for delivering a production service to around 10 million people and integrated across the various EHRs in London. It demonstrates, I think, the speed that we're able to use this approach and deliver value quite quickly.
Amazing. Okay, let's switch gears here a little bit. You also have developed Anessia, an application for health assessment of the elderly who are living at home. That's being used in France. Can you tell us about how Anessia is designed, what software it uses, how it functions, and some of the main benefits that you're seeing?
So here we're working with an association called PRISM, and this was formed by 9 founding members. This is in the Strasbourg area, or the Grand Est region of France. They have set about trying to establish an innovation platform, which they call Anessia. And the objective here is to allow innovation and digital health projects to grow more easily. I think historically, the barrier to entry has been too high for new applications or emerging opportunity. Access to data, governance, all these challenges needed to be overcome every time there was a service that needed to be delivered. So Anessia is really, how do they create a platform that solves all of these problems, provides that underlying data architecture that allows then innovation to sit on top of that and for them to very quickly roll out solutions to solve problems. So the first use case that we've been working on is, as you mentioned, as a nursing or community application for elderly people living at home. And this is for community nurses or health or social care teams able to visit the person in their home on their tablet or their device, be able to see an overview of the person's history, and also to complete a health assessment for that visit. This actually replaces a paper-based service. So the benefit there is real-time, up-to-date data for everyone across that care setting. And increasingly, as well as the benefits for direct care, that information can then start to be used for secondary use, understanding, maybe identifying patients who may be at risk, or patients who are actually doing quite well and maybe don't need another visit for a period of time. So they're able to actually sort of architect and engineer their service around the data that's collected in the home together with the elderly patients. That's the first use case that we're working on, and very similar to London really in terms of the technology. So again, openEHR is the underlying data platform that is the core of the Anessia platform. And we've built the nursing assessment form using the same low-code tools that we built and used for care planning in London. And that was surfaced again as a web application for those health and care teams. And again, this was delivered in approximately 4 or 5 months. So a similar time scale from inception through to live delivery.
I had a question. Both in One London and Anessia, it seems like they're very specific use cases. Is there a reason why you chose to kind of focus on one use case instead of, kind of addressing many larger issues at one time?
Yeah. I like that question. I think it comes back to trying to really focus on solving a problem and working back from a set of user needs. I think quite often in the healthcare data interoperability space, we can too often focus on the horizontal problems, spending years bringing data in and cleansing data. And meanwhile, patients and health and care teams are waiting for what's the thing that's going to help me do my job.
Yeah, exactly.
So the thing I love about these projects is we've actually said, right, this is a problem, end of life care planning. How do we get that live in 6 months and start back to the problem we talked about? people's DNA CPR preferences not being available. We've solved that, and that is in production now. Then you layer the other use cases around that, and you look at frailty or diabetes, and over time you start to deliver more value and build up a broader platform of information and data.
Yeah, that's helpful to think about, because I think the problem can seem so large to tackle with like the mountains of data and the multiple vendors that you have to start from somewhere. And I think this has been a great way, and also to get people to buy into it, right? Because you see the success of it in this discrete area, and then you're just going to get more stakeholders and more people excited to build on it.
And I think as well, as we start to shift, as I said at the start, to more of these regional sort of models of healthcare, there's problems that sort of bubble up at a regional level that are not necessarily well served by individual systems. So you kind of have these new and emerging needs of how do we actually solve this problem across an entire population of 10 million? And it actually needs that kind of service approach that's sort of built on top of the data in order to be successful, and also to complement the systems that are already in place.
That's a very important feature here in the US, to be able to complement the existing infrastructure that's here. So much has been invested in digitizing health data in the United States. And so can you talk to us a little bit about how openEHR does complement those types of existing systems?
At the core of openEHR, it's trying to establish an underlying data platform with open models. How do we sit alongside? So if you look at London, I think as a good example, where, I think there's 7 instances of Cerner that will continue to operate and function as normal. But what we have then to the side is an openEHR based platform that we've provided. We've solved a problem with end of life care planning. We're starting to bring data in from different locations. That's available via Cerner. So, the two sort of work in harmony with one another. And over time, openEHR can then sort of facilitate data to flow easily across a region. So whenever we want to add in other systems, maybe in mental health, and there's a different set of services there, you've got that foundation in place to support and complement those systems. And I think importantly, no single system will solve all the problems, even the best systems in the world. There's still problems that exist, and there's new and emerging problems all of the time that need a kind of more agile approach to development. And I think with the low code stuff, we're able to engage in more of an agile delivery where we can work with users, prototype ideas very quickly and get those into production without necessarily having to sort of get things on a roadmap and work through long delivery cycles. There's a few different sort of angles there to sort of making sure that we are able to complement. And it's exactly the same in Europe, to your point of the US. There's a huge investment and a lot of the systems are great and fantastic. It's just figuring out how do we open up the data and how do we solve some of these emerging problems that we have.
So do you see this as the future of digital healthcare?
I do. I think we're currently kind of going through a real transition period. I think we're seeing some of the biggest healthcare systems in Europe now adopting this. We've talked about London. We've talked about the opportunity in France. I think, you look at the Catalonia Health Service currently out to procure an openEHR based platform. They've been struggling with this idea of interoperability for years, the one where we move information around. And they've basically said, we can't keep doing this. We need to re-architect in this data-centered approach with openEHR. I think Wales have selected openEHR. We're doing another project with the Christie, which is the largest single cancer network in Europe. They're re-architecting everything around openEHR. So I think it's happening right now, and people are starting to see the benefits that it's delivering. This idea of opening up the data and making it available alongside the existing systems, I think it's here to stay, and hopefully we'll see more of it soon.
You mentioned Christie and the Cancer Network. Can you touch a little bit up on how openEHR can be useful for researchers and for the research community?
Yeah, so in the Christie, they're using it for both direct care and secondary use as well. I think to answer your question around research, I think what it provides is ultimately a sort of source of really well modeled information that can then be used to support analytics, population health, research. What you have as a byproduct of modeling and storing data in openEHR is a really well defined and semantic understanding of what the data is. And typically what we do, we don't try and solve all those problems within our software platform. There's lots of really great research and analytic capabilities on the market, and typically will integrate into those products and provide that data in that really nice structured format that can support researchers or data analysts in a way that meets their needs.
You spoke about, seeing the benefits. I think one of the issues in the US is that, interoperability is such a big issue and a broad topic. And we wanted to be able to provide our listeners with real life examples of how, achieving interoperability can create benefits to patients, to providers. I don't know, in your two use cases, I don't know if you have any hard data, but what kind of feedback have you been getting to show really what these benefits are?
The use case in London is just going live, so it's difficult to talk about the actual benefits. I think that in that and similar use cases, the perceived benefits are we can now start listening to patients and actually following their needs. So if in the case of end of life care planning, if someone actually does want to die at home, that we don't bring them in 2 or 3 times in the last months of their life into hospital. That's putting pressure on the healthcare system, but also pressure on the individual. I think in the Christie's, I was with the team there a couple of weeks ago, and the architecture they're moving from is they have a range of different applications following this centered architecture. And I think it was body weight. I can't remember the exact data item, but across those 11 systems, it was stored in 14 different ways using a different format in each case. For research, never mind direct care, trying to actually get what is the right body height or what is the particular vital sign, that becomes really difficult. So this movement towards a more data-centered architecture is something that really starts to eliminate that problem and allows us to create consistent services that sit on top of it.
I think this has been great to hear kind of examples of what's occurring now in Europe, and obviously we hope in the US to get there in the near future as well. Based on your experience and what you've been seeing, what do you see as maybe the biggest challenges when it comes to getting US stakeholders to really see the value of using openEHR in this way?
So I think we maybe touched on it. I think one of the, and it's not just the US. I think, first of all, I think the name sometimes openEHR, it's spelt openEHR. Some people can come away thinking, is it an open source EHR? Does it compete somehow with the Cerners of this world? I think the answer is very much no. It's very much focused on providing that modeling framework for the data. But I think the challenge primarily is, how does this sit alongside? How does it complement and not compete against the EHRs? So I think that is something that exists even in the countries across Europe that are deploying the EHR. So I would say that will be one area in the States as well. And I think my answer to that is the same as what we've talked about. Ultimately, I think as we try to move and there's different care models that are starting to emerge, I think the problems are similar in the States, and you'll need a slightly different approach to solving these problems that don't involve moving information around and creating lots of silos everywhere. So that is one. And I think another one is from maybe more of a technology one. I think there's sometimes some confusion around, okay, well, we've got FHIR in the States. Is this the same thing? And why do we need another standard? That's something that we get a lot as well. My answer to that is FHIR is a standard that's been designed for exchanging information through APIs and messages. And openEHR, I think, complements FHIR, but allows the data to be stored in a long-term and versioned way that will follow the patient for their lifetime. So again, those two really go hand in glove together. But again, there's sometimes a little bit of confusion and uncertainty with regard to them.
Alastair, recently you were quoted in a blog saying something a little different, a little twist on the idea here that is sort of prolific in the United States, that data is the new oil. Do you want to share that with us?
I think it was something along the lines of, my problem with talking about data as oil for me is a finite reserve that's tightly controlled and has made a small number of people incredibly rich. For me, we need to stop thinking about data in that analogy, because it's everything that data is not. Whatever the analogy is, well, I think I used currency as a means of exchanging and creating value within the system, whether that's right or wrong. But yeah, it's data should not be closed and owned by a small number of people. It should be open, and it should flow freely across these sort of regions and groups of healthcare providers. That's what we're working towards at Better.
Yeah. One really important point that caught my attention with that was that one of the things in the United States that I think to answer your question earlier, Nivedita, is that we struggle with reuse. The uses that HIPAA permit are clear and understandable. But when a data recipient seeks to reuse data, sometimes people get nervous. That analogy that you gave was really very poignant because it talks about the fact that data can be reused in so many different ways and make it so much more beneficial to the patient and to the provider.
Yeah, exactly.
Alastair and Karen, thank you both for joining the show today. It was a pleasure having both of you on and hearing this great discussion.
Thank you. Thanks for inviting me along. Hope to see you again soon.
And thank you to all of our listeners. I'm your host, Nivedita Patel. If you like what you hear today, please subscribe to the show. Diagnosing Healthcare is available wherever you get your podcasts.
Thank you for listening to Diagnosing Healthcare. For show notes on today's episode, additional episodes, and more insights on trending issues in healthcare, please visit diagnosinghealthcare.com and be sure to subscribe on your preferred platform. The Employment Law This Week and Diagnosing Healthcare podcasts are presented by Epstein, Becker, and Green, PC. All rights are reserved. This audio recording includes information about legal issues and legal developments. Such materials are for informational purposes only and may not reflect the most current legal developments. These informational materials are not intended and should not be taken as legal advice on any particular set of facts or circumstances, and these materials are not a substitute for the advice of competent counsel. The content reflects the personal views and opinions of the participants. No attorney-client relationship has been created by this audio recording. This audio recording may be considered attorney advertising in some jurisdictions under the applicable law and ethical rules. The determination of the need for legal services and the choice of a lawyer are extremely important decisions and should not be based solely upon advertisements or self-proclaimed expertise. No representation is made that the quality of the legal services to be performed is greater than the quality of legal services performed by other lawyers.